to thank the conference organizers for inviting us to present our work today. So seroadaptive behaviors are defined as choosing partners, choosing a sexual role, or deciding whether or not to use condoms based on a partner's HIV status. And an example of a common seroadaptive behavior is serosorting. So seroadaptive behaviors are common and shown to be increasing in some settings. And empiric evidence suggests that some seroadaptive behaviors may be protective from HIV. But with increasing antiretroviral therapy use and more frequent HIV testing, seroadaptive behaviors are evolving and becoming more complex. And recently there's been anecdotes of more nuanced seroadaptive behaviors emerging among MSM. And when I say nuanced, what I mean is making sexual decisions based on factors other than just partner HIV status. So for example, if an individual asks a partner for the partner's HIV status and the partner discloses that he's HIV negative, following up with a question of, well, when were you last tested, and then making decisions based on that. Or for a partner who says that he's HIV positive, asking the partner if he's on meds or if he's virally suppressed, and then making decisions based on those factors. So the objectives of this study then were to examine the prevalence of HIV test and HIV test positivity of two behaviors. First, condomless anal intercourse, or CAI, with HIV negative partners based on the timing of a partner's last test. And second, having sex or using condoms with HIV positive partners based on partners' ART use or viral load. We conducted a cross-sectional study in an STD clinic in Seattle, Washington between 2014 and 2015 for 15 months during that period. And within our STD clinic, more than half the patients are MSM. We enrolled men who are at least 18 years of age or older and reported sex with a man in the prior 12 months. And respondents were asked to complete a 5-minute computer-assisted self-interview, or CASI. And we subsequently linked CASI results to HIV test results from the day of the clinic visit. Within our CASI, there were 2 different modules to assess these 2 behaviors. The first module, that contained a series of questions about partner testing recency, was limited to HIV negative respondents who reported having a negative partner. We asked about behaviors in the prior 12 months and asked about the most recent HIV negative partner. Topics covered in this module included if the respondent asked their partner about the timing of the partner's last HIV test, if they used condoms with that partner, and if not, the reasons for not using condoms, specifically if they chose not to use a condom based on when the partner had last tested. The second module, asking questions about partner ART use and viral load, was asked of both HIV negative and positive respondents, but limited to respondents who reported having an HIV positive partner. We again asked about behaviors in the last year, but here we asked about HIV positive partners in aggregate, so we didn't ask specifically about the most recent positive partner. Topics covered in this module were similar. We asked respondents if they asked their partner about the partner's ART use or viral load, and if they made decisions about having sex or using condoms based on the partner's ART use or viral load. This was a visit-level analysis, so the unit of analysis was the clinic visit, not the individual, since men could complete the CASI more than one time if they made repeat visits during the study period. And we used chi-square-Fisher's exact test to compare proportions. So during the 15-month study period, we enrolled men at just under 1,800 of about 3,100 clinic visits. This includes about 1,500 visits by HIV negative respondents, 278 visits by HIV positive respondents. HIV negative respondents were younger than HIV positive respondents. The majority of our respondents were white non-Hispanic. And condomless anal intercourse, or CAI, with discordant partners is shown in the red boxes here. So 44% of HIV positive respondents reported condomless anal intercourse with a negative partner. 18% of negative respondents reported CAI with a positive partner. And the HIV test positivity among HIV negative respondents who were tested was 1.3%. So we had 15 men who tested newly positive for HIV. This first slide shows results from the first behavior of partner testing recency. And again, this was limited to HIV-negative respondents who reported having a negative partner. So of the 1,500 HIV-negative respondent visits, at 86% of those visits, men reported that they asked their partner about the timing of the partner's last test. At about 60% of these visits in blue, the respondent reported that their partner tested within the last 3 months, and 42% in the orange box reported their partner tested more than 3 months ago. And I should mention that of these 543 men whose partners tested 3 months ago, about 60% of these men reported their partner tested more than 3 months ago, but within the last 6 months. The other 40% was sort of a smattering of test times after 6 months, so within 9 months, a year, or after a year. So going back to the blue box, of the men who reported their partner tested within the last 3 months, about half reported condomless anal intercourse with that partner. And of these 361, 63% said that they decided not to use a condom with that partner because they felt the partner's last HIV test was recent enough that they didn't need to use a condom. This is compared to 40% of men whose partners tested more than 3 months ago. So these results do suggest that decisions not to use a condom with HIV-negative partners seem to be based, at least in part, on partner testing recency. Moving on to the second behavior, which is partner ART use and viral load. So again, we asked this series of questions of both HIV-negative respondents, shown in turquoise, and HIV-positive respondents, shown in orange, but limited this to men who had a positive partner. So a high proportion of both HIV-negative and positive respondents reported that they asked their positive partners about the partner's ART use or viral load. 2/3 of HIV-negative respondents reported that they made decisions about having sex or using condoms with their positive partners based on the ART use or viral load of their partner. And this was lower for HIV-positive respondents at 45% and 37%, respectively. We also examined the association between making decisions about having sex and using condoms with positive partners based on ART use and viral load, and the proportion who reported condomless anal intercourse with a positive partner, which is shown on the y-axis. So CAI with positive partners was reported by 83% of HIV-negative respondents who said that they made decisions about having sex or using condoms based on the partner's ART use or viral load, compared to 60% who had CAI with a positive partner and didn't report making decisions based on these factors. CAI with a positive partner was high among HIV-positive respondents, regardless of whether or not they reported making decisions about having sex or using condoms based on these factors, partner factors. Among HIV-negative respondents who tested for HIV the day of their visit, we examined the association between making decisions based on these factors and the HIV test positivity. And that's shown here. HIV test positivity, or the proportion of men testing newly positive, is on the y-axis. The ends within the bars are the absolute number of men who tested newly positive. You can see it's small. Among men who reported deciding to have sex or use condoms based on partners' ART use and viral load, 1.5% tested newly positive. And this is the group of men of whom 83% reported CAI with a positive partner. Among men who didn't report making decisions about having sex or using condoms based on partner ART use or viral load, the HIV test positivity was 6.5%. And again, this is the group of men of whom 60% reported condomless anal intercourse with a positive partner. So HIV test positivity was lower in the group of whom a higher proportion reported condomless anal intercourse with their positive partner. There are several limitations of this analysis. I've listed 3 here. The first, ART use and viral load questions, as I mentioned, were asked in aggregate, so we couldn't ascertain behaviors with specific partners. The low HIV test positivity within our study, it was 1.5% overall, yielded small numbers for our test positivity analysis I mentioned on the last slide. And the generalizability of our findings is uncertain. As Dr. Chan mentioned earlier, Seattle is sort of a unique place with a high proportion of virally suppressed individuals and a very frequent HIV testing. Most men in our clinic test quarterly for HIV, I should say mini-men. And so these results may differ in settings where those proportions are not as high, or other factors differ. In summary, many MSM decide whether or not to use condoms or based on partner HIV testing, recency, or ART use and viral load, at least in Seattle. And HIV testing frequency and ART use impact sexual decision-making among MSM. And the effects of these nuanced behaviors are uncertain, but appear to be potentially protective from HIV, though certainly more work should be done to better understand the individual and population level effect of these behaviors. And finally, our results somewhat question the utility of measuring condomless anal intercourse exclusive of other partner factors, given that our results demonstrate that many men are basing decisions about having condom use based on other relevant partner factors. So I'd like to thank the study participants as well as the clinic staff in the STD clinic in Seattle and the funding sources for this study.
There seem to be some questions.
Hi, thank you for the analysis, very interesting. Just to give a little bit of context for the people in the room who may not know, Washington State was actually the first state to approve a PrEP DAP in the United States. So I wanted to ask, obviously, an obvious question, was PrEP considered in the survey? Was it asked about? Because that could have a ginormous impact of whether I choose or not to choose, have condomless or not condomless sex.
I'm glad you brought that up, because as I finished talking, I realized I forgot to mention this. This is what happens if you don't put it explicitly in the slides. So at the time we did this analysis, PrEP uptake within our clinic population wasn't particularly high, so stratifying these results by participant PrEP use wouldn't have been informative. However, it's picked up certainly in the last year, and since the PrEP DAP is up and running and there's a PrEP clinic within our STD clinic. So within this same study, we do ask a series of questions about making decisions about having sex using condoms, a whole battery of questions based on partner PrEP use and self-PrEP use, but we haven't analyzed those data yet because we just added them recently. But certainly it's an extremely important issue, and I think will complicate this even further and really highlight sort of some of the complexities in measuring some of these behaviors, but I'm glad you brought it up because it's an extremely important point. So
super, I look forward to those numbers.
Stay tuned, thank you.
Hi, Philip Keane from the Kirby Institute in Australia. Thank you, that was very interesting. The data you showed on difference in test positivity among men who asked positive partners about viral load status or treatment status is very interesting, but did you, not sure if I missed it, but did you show a similar analysis on the men who asked their negative partners about recent testing, and also among the men who were tested positive, might they have had both condomless anal intercourse with positive partners and who they did ask about viral load, but also negative partners and testing history?
Sir, I'll answer your second question first. The answer is yes, they could have. This obviously doesn't say where they acquired their HIV infection. It's probable that many men who had condomless anal intercourse with a positive partner also had condomless anal intercourse with a negative partner, for sure. We don't have that data. To answer your first questions with partner testing recency, there was actually only one infection in that particular group, and so I would have to go back and look, but I'm pretty sure it was actually in the group who asked whose partner tested within the last 3 months, but with one infection, it wasn't a particularly relevant analysis. But we're continuing to collect data as well, so it'll be interesting to do an analogous analysis for the first part of this talk is for the second.
Thank you.
Thanks.
Hi, Anisha Gandhi from the HIV Center at Columbia University. Thanks so much for your presentation. I had two questions. One was whether there was any follow-up questions for persons who said that they chose to have condomless sex because they had a partner who had tested recently. If there was, or even if they hadn't tested recently, if there was any follow-up as to whether that partner acknowledged that they had not had any further partners since last test, and if that also could have affected decisions on whether to use condoms. A second question is whether there was any kind of analysis or questions around persons choosing to be an insertive or receptive partner, and whether those there were changes in that decision making based on partner characteristics. And third is whether you actually have collected like information on the individuals. I would just imagine in a kind of a multivariate analysis, the results might look kind of different if you're able to sort of pool results for one individual that might have riskier or less risky practices.
Those are all excellent questions, and I'm not confident I now remember the first two. I apologize.
No
I'll try. I should have had you stop after each one. I'm really bad at this, remembering multiple questions. So the third question was, I'm so sorry.
No, I'm
just give
happy
me
to
like a
repeat them.
one-word hint and I'll remember.
Sure. So the third question was whether you have individual identity so that you can kind of link responses over multiple visits.
Yes, we do, and that's planned. So thank you for that. We do have individual identity keys. We can link respondents over multiple visits and sort of, since many of our men return to the clinic, look at this in a somewhat longitudinal fashion. We'd like to do that, and that's planned, as well as by other individual characteristics that we have of these patients.
So the second question was whether you have information on whether people were either insertive or receptive partners. Yeah.
We do. We didn't ask that specifically in the context of these two modules of this study. We ask it as part of our routine clinical questions of our patients about if they had insertive or receptive sex with partners stratified by partner HIV status. So we could look at that in sort of an ecological way. We don't have it specifically tied to these data, but I think that's extremely important because it's possible, and I can look at this, it's possible that the condomless anal intercourse reported with by HIV-negative respondents with positive partners was primarily insertive versus receptive, and I think that's a really important thing to look at. Thank you for bringing that up.
And then my final question is just whether there was any kind of
The
further
follow-up,
explanation.
right.
Yeah.
The short answer is no, that we didn't go in depth with that, which I would really like to do. This survey is actually built into our routine. It's a research study, but it's built into our clinical computer-assisted self-interview, and so we had to keep these questions quite short for clinic flow because it's done on the same computers within the same clinic. But it's certainly something that I think if we were to do another analysis or if others are doing something similar would be really, really important to look at. So thank you for bringing that up as well.
Thanks so much.
Thanks.
Giulio Maria Corbelli, European AIDS Treatment Group. I have a word question. The study is conducted in 2014-2015. So I wonder if you have some previous data or if you collected some data trying to understand whether a larger availability of information, scientific information, such as the results of the partner study, could have had an impact on the decision-making based on viral load.
That's a great question. We don't have these same data for any time period before 2014, these exact data. Though I'm going to say this wrong, and maybe if Susan or Julia is here and they want to step to the microphone. In terms of in Seattle, we do Pride surveys every year, surveys at the Pride events, a given weekend in June. And I know that they were tracking the proportion of individuals who knew that being virally suppressed conferred a lower risk of HIV. And I think that's pretty high. Julia's coming to the microphone now, so maybe she can answer.
Yeah, and I have a poster that shows the trends. But yeah, we've seen an increase in the proportion of respondents who are aware of treatment as prevention. And there are, as of 2 weeks ago, 50% of our 2015 Pride survey respondents 50% of HIV-negative Pride survey respondents who are MSM indicated that they were aware of treatment as prevention.
Is there data before 2015?
Right, yeah, and we've
It's
been
gone up.
asking that since 2009. If you go to my poster, you can see how the
Okay.
numbers have changed.
I assume
each
they've
year.
gone up, yeah.
They've gone up.
Yeah. So we have some data from Seattle as a whole, which is informative.
Great, thank you.
Okay, thank you.